Screen here and introduce Michael Kent, who's the Hazardous Material Ombudsman with Contra Costa Health Services Department. And Michael, go ahead and take it away.
Okay, well, good morning, everybody. Can folks see my presentation?
Yeah, we got it.
Okay. So I'm Michael Kent with the Contra Costa County Health Department, or Contra Costa Health Services, and I really appreciate you having me here today. I'm going to be talking about sort of an attempt to uh, perform the type of projects that you heard about from Brendan and others to integrate energy efficiency programs with health department programs to connect medically vulnerable residents with energy efficiency services. And before I begin, I just want to give a little shout out to Damian Hardman, who I liberally borrowed a number of these slides from. So one theme you'll be hearing throughout my presentation is that coordination and cooperation between agencies is really important. And I guess that's the first lesson. So most of the folks here probably know Contra Costa County in terms of our demographics. It's pretty diverse. Now we have high rates of poverty, but it's, things aren't spread out evenly throughout the county. In Contra Costa County, we have a number of disadvantaged communities per Envirus screen, mostly along the waterfront in the older industrial areas. And you can see from these slides in these disadvantaged communities is where a number of our oil refineries and chemical plants are. And I'm going to be talking about this from a public health perspective and a climate change perspective, because that's how I got into this work. And so the approach that the public health community takes to climate change and the focus we have is that the impacts of climate change are going to disproportionately impact vulnerable populations already suffering health inequities. And so when we engage in efforts to address climate change, that's our focus. How is affecting vulnerable populations who are already suffering health inequities? So in Contra Costa, in the health department, we had a small climate change program that tried to look at our climate change issues. One of the very first things we did was sort of a health co-benefits analysis of all the mitigation measures were in our climate action plan. So what were the other things that they provided besides just reducing greenhouse gas emissions? And we followed that up with a study on what our vulnerabilities were and focusing on heat, because as you know, heat is one of those things that's already a problem, even without climate change, and of course is projected to get much, much worse over time because of climate change. And so we did an analysis of the county and saw that different parts of the county were more impacted or more vulnerable to the impacts of heat than other parts of the county. And you see these, for the most part, except for that small red area down in the south central part of our county, line up pretty closely with our disadvantaged communities. And the reason that small area in the south center part of our county is there is because it's a very large retirement home with seniors who are vulnerable. But so you see a lot of correlation there. And in the public health field, we try to address problems in health through what we call focusing on the social determinants of health. I mean, Contra Costa County as an health department is an integrated health department. We have a hospital, we have clinics. We treat a lot of patients in the county, mostly our Medi-Cal patients. We have our own health plan, and we do a lot of medical treatment. But the theory we work under is that really most of what influences people's health is not the type of medical treatment they get, but their living conditions. And those living conditions are an outcome of social inequities and institutional inequities that lead to disparate living conditions. And housing is no different. You know, our poor housing quality in many parts of our communities is an outcome of intentional discriminatory housing policies. And so, you know, that's the bad news. The good news is because these conditions were created by policies, they can be changed by policies. And so it's incumbent on us to try to find efforts and things to do to change those housing qualities to get at disproportionate health inequities. And so when I was thinking about heat, following up our study, it was like, well, what could we as a health department do to address the health inequities that were going to be caused by heat? And like many people, the type of things you work on come out of a personal experience. And, you know, I'm just going to briefly touch on my personal experience. I live in the city of Alameda, where almost nobody, including myself, has air conditioning because it rarely gets really hot. And I live in a small 1,200 square foot home that wasn't insulated because it doesn't get very hot there, and had very, you know, built in 1925 and had a water heater from the 1970s. And so when I moved in, initially this is the therms of gas I used, you know, were 655 a year for about 3 years. And then I replaced my water heater in my furnace, and I got a 29% improvement to 464 for a few years. And then I had my house thoroughly insulated, and I got another 37% increase to a total of a 56% drop in gas usage from the time I moved into 2018, or about $40 a month savings for me. And, you know, for me, that's not a huge amount of money. I spend more than that at Starbucks. But, you know, for somebody who's on a limited income, that's quite a bit of money, money that they could be using of it for other things. So I was happy about that. But, you know, what I also found is that there were a lot of other benefits and health benefits. And I really, on a personal level, found the health benefits of weatherization. In addition to reducing energy consumption, I found that my house was much cooler in the summer. And so, you know, the few days that I got 95 outside, it was still only maybe 78 degrees inside my house. So a huge difference in terms of comfort and cost savings. Like I said, if you're on a fixed income or a low income, leaves more money for essentials. It also leaves less likely that you might get your energy disconnected, which is one of the leading causes of homelessness. But I also found it kept my air filter much cleaner. It keeps particulate matter out, making the air easier to breathe with people like me who have asthma. And it also can help keep out moisture, which can reduce insect pests and mold, which are both asthma triggers. So I said, well, how can I translate that into working with the health department? And so in our public health department, we have a public health nursing program that goes out and does visits to our patients throughout the county. And in the county, we also run our own LIHEAP program that's actually done in-house in our Department of Conservation and Development. And a few years ago, we also had what we call LIHEAP funding in Contra Costa, that was state cap and trade money through a nonprofit Build It Green. And so I thought, well, you know, what if I was able to get our public health nurses to refer their patients who are all medically vulnerable to these energy efficiency programs that could help them on a health basis. It helps address this health inequity problem. And so I did that. I connected the two departments who had never heard of each other. And we ran a successful pilot in 2017 and 18, where we developed some screening questions for the public health nurses to ask. We got a bunch of referrals. I helped clients fill out the weatherization applications. We had 17 different public health nurses participate. For a lot of reasons, we were only able to get 8 people through the project. One that was touched on by the Marin presentation was difficulty in getting landlords to agree to participate. And we were funded by the state health department to use a group called RAMP to write up this report for other health departments to share with other health departments around the state in case they wanted to partner with their weatherization programs. So then we thought, well, okay, we feel like this could be a successful model. Where do we go to next? And like I said, ours is a program of partnerships, and I realized this is something we couldn't do on our own. And so we decided we would broaden our partnership. And while we were working on this pilot, I came in contact with the Marin Green and Healthy Homes program through MCE, a woman named Michelle Noshishoki, who runs that program there. And I thought, well, wow, this is something we would really be interested in trying to replicate in Contra Costa County. And it turned out they had a grant program going to look at how to do in-home asthma trigger assessments to reduce asthma levels. And so we partnered with MCE and with the Department of Conservation and Development, and Bayron, through Bayron, they run their program as well as our LIHEAP program, and their contractor, the Association for Energy Affordability. And we applied for a grant from Green and Healthy Homes, to look on at doing asthma triggers assessments in the county. And first to develop sort of a business plan. The grant was technical assistance from Green and Healthy Homes to be able to make the case that if we put money up front into doing this type of preventative asthma work, it would save us money in the long term in terms of avoided hospitalization and emergency room visits. And again, asthma in Contra Costa County is not equally distributed. And you can see once again, areas in red where we have high asthma rates are the same as those disadvantaged communities, and the same where we have high heat. And if you match that up with income levels, it would be the same as income levels. And housing stock is one of those factors that lead to high asthma rates in those areas. And those also happen to be the areas where we have the highest concentrations of low-income minority residents. And so again, not just asthma or not just housing, other factors contribute to the fact that there's the higher incidence of asthma hospitalizations in these areas, but housing stock is certainly part of the problem. So in 2018 and 19, we did that study and did that business plan. And then we applied for another grant from the Green and Healthy Homes Initiative to try to implement that program. And it just turned out serendipitously, really, that the state of California was releasing some money, $15 million one-time set aside to programs around the state to do asthma in-home trigger assessments. And they opened that up just about when our program, our first business plan was coming to a close. And so we applied for that grant back in April, right when COVID started. And in August, we were awarded that grant. And so it's a 3-year grant, enable us to do 150 in-home asthma trigger assessments. But like I said, our program, we were trying to partner. And so we wrote money into the grant that in addition to doing the assessments through our health plan, public health nurse and community health worker, we would intentionally partner with our weatherization programs in our Department of Conservation and Development, both the LIHEAP program and the BayREN program through Association of Energy Affordability to get those residents into the weatherization programs and to get more bang for our buck, to get some synergy, to really be able to provide them the most benefit that we could from those 2 programs. And then also the Bay Area Air Quality Management District heard about this program and were really interested in it because of its greenhouse gas reduction capabilities and also to improve air quality. So they gave us additional funding for 1 year to augment at least 38 of those assessments to pay for improvements that maybe neither the state grant nor the weatherization programs could pay for that would improve indoor air quality or reduce greenhouse gas emissions, things like air filtration or possibly converting gas stoves and gas appliances to electrical appliances, if neither of those other two programs could pay for them at a given home. This is just kind of an overview of our program. Like I said, the health plan will be coordinating home visits with the weatherization assessments. Because of COVID, we're going to be starting out doing those remotely, and there's precedent for doing that around the country. Green and Healthy Homes is helping to keep us connected with other programs around the country that have already started that work. We'll do the home assessments, we'll do trigger remediation, and we'll do weatherization. And this is just a flow chart of sort of how our various visits will go and who will be doing the work. We're also coordinating this with more intensive clinical management for those patients, as well as asthma education and medical management. And then, like I said, mitigations for asthma triggers, and then weatherization that are both asthma trigger, energy saving, and other benefits. And so that's the program. We're just getting started, and we should be starting our home visits pretty soon. But like I say, this is an opportunity for us to partner. Obviously, this is something the health department couldn't do just on its own, and so happy to answer any questions about it. Thank you.
Great, thanks, Michael. Give it a couple minutes for questions to roll in. I do want to point out that Michael did his energy efficiency project backwards. We recommend folks do insulation first before mechanical, but yeah, that's I'm just playing around. They're both fine.
So I do see a question in the chat. Maybe it was from an earlier presentation, but it asked how the LIHEAP WIP program and the LIHEAP program work together. And again, the LIHEAP is state money from cap and trade, and LIHEAP is federal money. And as far as I know, they're not necessarily directly connected. In our case, in our pilot, what we did was when we found a client who was interested in applying, we sort of triaged. And for the ones that were in disadvantaged communities, we referred them to LIHWIP. Ones that were not, we referred to LIHEAP, because LIHWIP only worked in disadvantaged communities. And also, we did have a case where they were not a citizen. Nobody in the household was a citizen or a legal resident, and LIHWIP was able to help them, whereas LIHEAP was not. But I understand Kellen wants to answer that question, so I'm going to go ahead and let him do that or add to that.
Well, that was for, I believe that was for the CAM presentation, so we might get to that in the panel. But here's one from Payal. Challenges you faced in replicating a project from different county in Contra Costa.
I'm sorry, I don't understand the question.
Yeah, I'm trying to see if I can.
I'm happy to ask Payal to unmute. Maybe that'll help clarify.
Yeah, good idea.
Hi. Well, actually, in one of your earlier works, you said that you replicated a project in Costa County, right? From some other, maybe you partnered with some other county, and then you want to replicate the project.
Well, after we did our pilot with the public health nurses, well, while I was working on the pilot, I learned about the Green and Healthy Homes Initiative in Marin County. And, ultimately that's where we would like to head, is to be able to incorporate, other home issues like spill and fall prevention, lead poisoning prevention, asbestos, radon, other in-home things, water conservation. We're not there yet. We're kind of taking it stepwise, and right now just trying to connect our health department with the weatherization to be able to focus on medically vulnerable populations. But yeah, ultimately we would like to be more comprehensive, similar to what they have in Marin.
Do you anticipate some challenges that you may face in the future doing that?
Well, yeah, I mean, one challenge that we're already facing and programs face is the siloed nature of funding, and so, weatherization will pay for one thing, the state asthma grant will pay for another thing, but, at a home, they might have some other problem that really needs to be solved. Like, let's say you have a leaky roof that's causing mold problems in the home. Well, if neither program will pay for that because it's too expensive, the state caps their expenditures per home at $1,000. Where do you get that money? So we're looking for unencumbered sources of funding and also stable sources of funding. It's hard to run a program off of grants every year. Another challenge that we'll face, and it just keeps growing the more programs that you incorporate, is data collection and sharing. Especially the health data from people is protected data through a federal and state program called HIPAA. And you have to be very careful about how that data is shared. You have to have special procedures in place to make sure it's secure, special agreements put in place. And it gets kind of complicated. And so the more programs you have, the more complicated your data sharing is going to need to be. And I see that as a big challenge, not being a data person.
Thank you very much.
Great. Thanks, Michael.